This presentation will be given by Dr. Santrein Pasricha. He is Division Head of Population Health and Immunity at the Walter and Eliza Hall Institute of Medical Research at the University of Melbourne in Australia. His areas of interest are defining diagnostic test accuracy of hepcidin as an index of iron deficiency and synthesize the evidence of iron interventions in children and women characterizing the epigenetic regulation of hepcidin. He has many scientific publications, and we're very happy to have you here.
Thank you. So thank you everyone for coming back, and I know that I'm the last thing between afternoon tea and sort of a rest followed by dinner. So, hopefully I'll be able to keep you awake. So what I'm going to talk about now is a problem that has been complex for a long time in nutrition, particularly in public health nutrition. And I'm really going to focus around the question of anemia and iron in young children, in babies. As I'm sure you're all aware, there's a lot of anemia in young kids around the world. 273 million children have been estimated to, under 5 have been estimated to be anemic. That's just around the world, 43% of all kids under 5. That's an enormous prevalence. And of course, there's lots of anemia. The greatest absolute number of anemic people is among non-pregnant women, but also, and there's also a lot of anemia in pregnancy. But I'm really pleased that this is a largely clinical audience. Often I give talks to nutrition audiences, and I'm a clinician, I'm a hematologist, and we see a lot of anemia clinically. And as you know, anemia presents with reductions in hemoglobin concentration, can cause fatigue or lethargy, and patients come to see us. But when we are seeing a patient with anemia, we have to obviously think of the most common causes, but there are many causes of anemia. There's textbooks full of causes of anemia. So of course it can be related to iron deficiency with your typical microcytic hyperchromic blood film, but it can be associated with all sorts of other causes, particularly around inflammation, which is a more of a normocytic normochromic blood film. But you can also see infection with parasites. Or particularly malaria. It can be related to hemoglobinopathies, and in India there's many people affected in tribal areas with sickle cell disease, and also there's a lot of beta thalassemia and E-beta thalassemia. And it can be related to other conditions, other micronutrient deficiencies, for example, such as B12 and folate deficiency. But why is it then that young children are at such a high risk of anemia? So here it probably is largely related, there is the chance that it is in some ways related to iron use. So children grow rapidly. Children really just have an enormous doubling time in their size. And a little baby turns into a big baby, turns into a toddler, can walk and run away from you all in the space of 2 years. And so these children are growing and growing and growing. And in that time, they need iron for their red blood cells and for their tissues. They also have changes in their diet, and they change from reliance on breast milk through to the introduction of complementary foods. And in low-income countries, children also suffer the onset of inflammation. They become exposed to the world, and the world is an inflammatory place. But what's also important is that following this period of rapid growth over this first couple of years, children, of course, slow down. So if I've got a 3-year-old who is, so I've got a 5-year-old, and he's not that much bigger relatively to when he was a 3-year-old compared to a 2-year-old and what they're like when they were just born. And so in many children, anemia actually, in children, anemia often self-corrects. So this is data I just found from the DHS, but you can get your own data, and this is from India, and you can see that the prevalence of anemia goes up between 6, 12, 18 months, 2 years. It sort of peaks around the 18 months to 2 years time. And this is data from India and also from the Gambia. And then you can see that the prevalence of anemia starts coming down again. So there must be children who are anemic at the age of 2 who are no longer anemic by the time they're 4 or 5. So children who are anemic under 2 are not committed to a lifetime of anemia. Most of them will start getting better. And for those of you who've seen data, in older children, the prevalence of anemia continues to decline. The one important question that I'm going to deal with is how we go about dealing with anemia. So I've shown that there's a lot of different causes of anemia in the textbook. Anemia is prevalent in young kids, but the question is, if we give iron, a really important question has been how much of that iron is amenable to iron interventions. And so WHO analysed their data, and they believed that actually much less than 50% of the prevalence of anemia is responsive to iron, particularly in young children in sub-Saharan Africa. You see that it's only about 32%, and in the Asian region it's only about 40%, and in the Eastern Mediterranean region also only about 40%. In other words, iron interventions will not correct the majority of the cases of anemia. And indeed, there's been other analyses that have shown similar findings. Indeed, this one was published a couple of years ago, which suggests that globally, in young kids, only about a quarter of the anemia is actually attributable to iron deficiency per se. This is really a lot less than the 50% that we all, the 50% figure that we've been sort of had drilled into us when we sort of initially get into the field. So how do we treat anemia clinically? So many of the people in the room are clinicians, and so what happens for us is a patient comes to see us. And a patient comes to see us and the mother will say, there's something wrong with my child, she's a bit tired, or she's a bit pale, or she's a bit irritable, and maybe we'll do a blood test or make a diagnosis, and we'll diagnose this child with anemia. And then maybe we'll follow a pathway of clinical management, which may vary depending on your clinical preferences. But ultimately, you'll think about this case. That's what I want to say. You'll think about this case and you'll make a decision about how to treat the patient. And then maybe you'll give the child some iron. And then you'll come back, and then the child will receive the drugs. And ideally, someone will keep an eye on that child. They'll make sure the child gets better. You might even test the child again, and you'll make sure there's a response. So this is a very monitored situation. At the population level, we've previously published similar to what Lynette showed earlier. There's a lot of complexity around the determinants of anemia and iron deficiency anemia, and it's more than just a simple lack of nutrition. There's both immediate consequences and upstream consequences, and this is overlaid by infection, inflammation, malaria, genetics, and then things such as the healthcare systems. So it's a very complex picture. But ultimately, what are the ways that we say that we should try to fix anemia? Well, there are really two important guidelines that are used, and both of them revolve around giving iron. There's iron supplementation, and there's multiple micronutrient powders which contain iron. And so the World Health Organization recommends that all children under 2 in an area where the prevalence of anemia exceeds 40% should receive iron drops, or where the prevalence of anemia is above 20%, which is actually the majority of developing countries in the world by far, that all children should receive multiple micronutrient powders. So we've all seen these sort of drops. They're not cheap. Particularly micronutrient powders, it's not cheap, $0.03 per dose, for example. So these are the ways that WHO and the current recommendations advocate resolving this very complex problem that I've just shown you, give iron. Now, the thing is, I showed you how we clinicians would treat a patient, but when you're giving universal iron interventions, it's a completely different story. Here, you're giving iron to all children in a population, regardless of the individual diagnosis of that case. And the argument that people make is that you're trying to treat some cases and prevent anemia in other cases. But not all children will experience a benefit, because you're seeking an improvement in the overall population. So there will be some children whom you are giving the iron to, but they themselves will not experience a benefit. So this is modelled, I guess, I'm not sure, but I guess this is modelled on other sort of vertical healthcare interventions, for example, immunisation, where we try to protect a whole population. But in our case, when we're giving iron, we're often successfully integrating this perhaps into other healthcare systems and other healthcare programs, but the healthcare workers are busy. They've got a lot to do, they've got limited training on this, and they may not be able to provide that follow-up of each individual child the way that clinicians look after an individual patient. So there's not necessarily a lot of follow-up or training, and ultimately, in my view, that means these interventions really need to be safe. But as we know, and as anyone who's ever worked in microbiology and has had to culture bacteria would know, humans are not the only species that require iron. Pathogens also require iron, and there's been a lot of discussion around the different mechanisms that pathogens, particularly bacteria and some parasites, require iron to thrive and grow. So when I think about whether or not we should be giving iron to a population, I think what we need to do is we really need to think of the potential benefits of giving iron to a population and weigh that up against the possible risks. And I guess the possible benefits, as I see them, would be obviously around improving anemia, but also maybe in improving child development and possibly having an effect on growth. And what would the possible risks be? Well, just to start with for now, I would say the risks around infection, specifically around malaria and diarrhea, is what I'll discuss in detail now. So, there is absolutely no doubt that giving iron to children improves hemoglobin and reduces the prevalence of anemia. Indeed, systematic reviews, including the one we did here, which was looking at all the trials that are given daily iron supplementation to children under 2 years of age, showed that you see about a 35 to 40% reduction in the prevalence of anemia when you give iron. And you see a reduction in iron deficiency as well. And likewise, this is a systematic review done a couple of years ago on micronutrient powders, and you see a similar sort of, I can't say that, about a 34% reduction in the prevalence of anemia when you give iron. So iron, these trials, not comparing iron to MNPs, but two different sets of trials, do come up with similar effect sizes on anemia. And similarly, you see about a 60 to 70% reduction in iron deficiency. So that's clear. So we do see, efficacy trials do see this advantage on the biochemical endpoints of anemia and iron deficiency. But it's also important to note that iron interventions really don't look like they're going to eradicate anemia. But there is a change in the way that the world is starting to see the way that outcomes should be assessed for evidence. So in the United States, as an example, the US Preventative Health Task Force says that to make a recommendation on a clinical service or treatment or preventative service, the evidence needs to show an effect on health outcomes. Now, these are outcomes that patients feel, outcomes that patients experience, and it's about their quality of life. So this might be things such as shortness of breath, quality of life, functional status, or child development. They do not allow evidence to be made based on intermediate outcomes, such as blood pressure, cholesterol, vitamin levels, and so forth. It needs to be on a clinical endpoint. And so what does the US Preventative Health Task Force, when they synthesized the data around looking at, and this was about screening for iron deficiency anemia in babies, because obviously in the US they wouldn't recommend universal iron interventions, they said, we don't know. No one's looked, we don't know whether it's advantageous to start finding out about anemia in kids. And indeed, the FDA, which is obviously the most important regulator in the world, probably for development of new drugs, insists that drug manufacturers coming up with a new drug, be it a cancer drug or a hypertension drug or a cholesterol drug, you're not allowed to just go after your intermediate outcome in your trial. You have to go for an outcome that is important to the patient. So, back to us. Does that mean that we're allowed to use anemia and iron deficiency as our outcomes? Does that mean, how often will a patient come to us and say, oh, doctor, my hemoglobin's about 10.3. I just don't feel right. I'm really suffering from low hemoglobin. They'll come and say, I don't feel well, I'm fatigued, or maybe that my child's not growing properly or not developing properly. So these are the outcomes, in my opinion, that we need to be really focusing on. But when we look at these outcomes, the data rapidly becomes thin. And indeed, we did a systematic review a few years ago looking at the effects of iron on child cognitive development in children under 2, and we were unable to show that there was a benefit. But the reason that we were, and when we looked at MNPs, this is another systematic review. Firstly, there were no trials that were of high enough quality that looked at iron on child development at this time in the systematic review done by Luz for MNPs. But when they looked at growth, there was no effect. So these outcomes that really matter to kids, we're not able to find the evidence. But if you look at older kids, so when we did another systematic review of kids at school, so these are children in primary school, so 6 to 12 years of age, we did see a benefit of iron on child development. So the question is, why are we not seeing the effects from iron in young kids? Could it be that there isn't an effect? So maybe anemia and iron deficiency don't affect brain development, or maybe that brain development is refractory to iron interventions in this age group because the damage that has occurred is irreversible. Maybe we can't detect an effect because of existing tools. But more likely, we just haven't looked. We just haven't done those studies. So indeed, when we looked at those systematic reviews, you may not have seen, but the total sample size of those trials across all those few numbers of trials was only about 500 per arm. That's not a lot of people in a randomized controlled trial. It gives you a very underpowered effect size. However, I don't believe it is safe to assume that there's a beneficial effect. Just because we hope there's a beneficial effect or we assume there's a beneficial effect, I don't think that's safe, and I'll tell you why. It's because there are some studies that have looked at the long-term effects of iron given in other ways. For example, this is a study done in Chile, a famous study which looked at giving high-dose iron-fortified complementary food versus formula versus low iron-fortified formula. And then they followed the kids up. This is the advantage of getting older. They were able to follow the kids up for 10, 15 years on. And what they found was that in all developmental and behavioural outcomes, the children who were receiving the higher dose iron-fortified formula were performing more poorly. Now, it's unclear what the explanation is, but there are plenty of hypotheses that there may be poor regulation of iron access to the brain when infants are young because of an immature blood-brain barrier. Therefore, my point for this slide is that we can't make any assumptions. So, at the moment, I would say we're up to that there's benefits on anemia, which we're maybe not allowed to use, and the effects on child development and growth are not shown. What about the risks? Well, I'm sure many of you are aware of this seminal randomized controlled trial. I try not to keep talking about trials from 12 years ago, but we can't stop talking about this one. And this is a trial that was performed in Pemba Island, Tanzania, where it was powered at, I think there were about 17,000 children or more, 27,000 children randomized onto this trial, and they were hoping to show that when you give iron to everyone in the population, you see an improvement in mortality. But they saw the opposite. There was an increase in serious adverse events, which is always defined as hospitalization or death, by 12% in the children randomized to iron. There was an increase in malaria-related adverse events. The trial had to be stopped by the Data Safety Monitoring Board early, and this prompted emergency changes to the WHO recommendations and resulted in a stopping of giving universal iron supplementation to malaria-endemic parts of Africa. And actually, when a systematic review was done, what they found was that it's one of the most amazing systematic reviews to read, but what you see is that in areas where malaria prevention is given along with iron, sure, you don't see an increase in malaria, but where malaria prevention is not given along with the iron, you see an increase in the clinical risk of malaria. Now, if you imagine a sub-Saharan African or maybe a malaria-endemic part of Indian environment where you have different programs, you need to consider whether the iron interventions are being delivered in partnership with highly effective malaria prevention interventions. And one hypothesis for why iron may be exacerbating the risk of malaria is some interesting data done by Andrew Prentice's group and his colleagues in the Gambia and also in UNC, where they showed that iron supplementation, as we all know, when you recover from anemia, you must go through a period of reticulocytosis of young immature red cells to be formed and entering your blood. And it's been known for a long time that young red blood cells are favored by parasites for invasion. And therefore, it may be that during this period of recovery following iron supplementation to an anemic individual, there's a transient increased risk of malaria during that time. But it's not just malaria. So this was a trial done looking at the effects of iron-containing micronutrient powders to see whether they were safe and effective in Ghana. But what was worrying about this trial was that they didn't see much effect on anemia, but they did see an increase in hospitalization by about 23% during the period of intervention. Now, they didn't actually use these words in the report, but I'll say them. This was an increase in serious adverse events associated with iron-containing micronutrient powders. That's the only way to describe their finding. And there may be effects of iron on other infections. So this was a trial in Pakistan performed and published at a similar time to the Sufi trial, to the Zlotkin trial. And this trial randomized children to iron-containing micronutrient powders and also versus control, where control in this case was no intervention. So this was not a placebo-controlled trial. But here they found increased reports of diarrhea, increased bloody diarrhea, increased evidence of parental reported chest indrawing, which they interpreted as respiratory infections. But this trial had no placebo, making the findings difficult to be secure about. But these studies and others have really triggered an interest along a second line of danger associated with iron interventions, which is the effect of iron on the intestinal microbiota. And as someone raised earlier today, there are a few studies now that show that iron fortification in young kids increases the abundance of pathogenic intestinal bacteria at the expense of commensal bacteria that are protective. And this has been shown now a couple of times by Michael Zimmerman's group. And what's interesting is this seems to predominantly occur in areas where the carriage of such pathogens is already high. And indeed, there was a systematic review here which showed that there was indeed a small but significant increase in on diarrhea from micronutrient powders. But I just want to show you, so this was a 2013 systematic review, and then the next systematic review looks totally different. And we see this all the time in our evidence for iron interventions and micronutrient, especially around micronutrient powders. Finally, just on a more recent study from Michael Zimmerman also showed that there seemed to be, in some studies that he did, an increase in respiratory tract infections in children receiving iron interventions as well. And this opens yet another area of research into the interaction between iron and microbes and infection. What are some other risks of iron? Well, this is one that I feel hasn't really been fully discussed yet, and I think one that is probably the next era of concern around iron. So when people have anemia, they obviously want to absorb more iron to be able to restitute that anemia. And that can be physiologic if you're recovering from anemia, but it can also be pathologic if you have a genetic condition that renders your red cells more fragile, such as thalassemia. And so people with thalassemia, or people even with thalassemia traits, I'll show you, have an increase in a hormone that causes them to absorb more iron. Now, this writ large across a population, there are hundreds of thousands of people around the world, or millions, who harbour carrier status for hemoglobinopathies. And the reason they do that is because it's protective against malaria. So we have an environment and a world where there is a lot of iron deficiency, malaria, inflammation, and hemoglobinopathy carriage, all in the same parts of the world. And we've shown that the hormone that regulates your iron absorption is set at a level to allow you to absorb more iron if you carry a hemoglobinopathy. And in particular, Michael Zimmerman's group have also shown that you actually absorb more iron when you carry a hemoglobinopathy. And if you actually have a compound heterozygous or homozygous state, so you actually have disease, in some cases these diseases can be subclinical, so thalassemia intermedia, hemoglobin E beta thalassemia, and HbH disease are all common hemoglobinopathies in Southeast Asia and South Asia. And these conditions can actually be subclinical, but they render you highly likely to absorb a lot of iron. One other issue that I find alarming, because as a clinician sometimes we see this in our patients, is iron poisoning. So one of these is a jelly bean, and one of these is an iron tablet. Can you tell the difference? Now, if a young child consumes even 1 or 2 iron tablets, they are at extreme risk of death from iron toxicity. the iron toxicity and acute iron poisoning is one of the most horrible ways to go. You suffer a metabolic acidosis and gastrointestinal perforation, and it can only be treated in really a very high tertiary or quaternary referral centre. So the doses in someone who doesn't weigh very much are very, 10 tablets. So if a child managed to eat 10 tablets, we're in deep trouble. Now, in the US during the 80s, poisoning from iron was the most common cause and caused 30% of all toxicological deaths in children. Now, in low and middle income countries, in some countries, and I think in India is one of them, they use blister packs to give iron to pregnant women or women, for example. But there are many other places where the iron is given, for example, just in a little bag or in maybe even just a newspaper envelope. Can you imagine how excited the child might be to discover the lollies at home? So I think what we have is we have some putative benefits from iron and we have some potential risks from iron. So how do we start putting all this together to understand whether or not it's worth giving iron? And I think this is just too hard. It's really complex, and there isn't really a straightforward answer here. Obviously, there are policies recommending giving iron, especially to young kids, but I think I was really thinking about this, and I was trying to understand how you get at this. And I think you need to start thinking about using a moral or an ethical approach. So there are medical ethical principles around non-maleficence, which is first do no harm, and around autonomy, around the individual rights of a patient or a family. And then there's consequentialist ethics. So this is the concept of doing the greatest good for the greatest number. And this is really a distillation that leads to the burden of disease approach in anemia, to burden of disease approach to allocation of resources. So just putting these concepts together, if the first concept is to do no harm, it's the basis of this principle is that if there's a certain problem, it might be better to do nothing than to risk causing more harm. And so what's the analogy here? That sometimes programs that are implementing MMPs or maybe iron supplements to young kids are just ill-equipped and cannot detect small increases in infection. And therefore, they're not able to necessarily provide security that they're not causing any evidence or any harm. And around autonomy, so the autonomous person, this means that a person should be provided enough information to make a decision for themselves, and they may make a decision that is actually counter to what the medical or clinical professional believes is in their best interests. We can't force patients, for example, to go through chemotherapy for a cancer because their values may be that that's not what they want to do. But when we're distributing iron or MMPs to populations, are we always giving enough education and consent prior and full information prior to provision of the drugs? Secondly, the other approach is, of course, trying to think about this in terms of the greatest good for the greatest number. And here, what we have to weigh up is what is worse, anemia or malaria or diarrhea? And the way you can start thinking about this is taking a global burden of disease approach. Now, the burden of disease centers on a concept called the disability-adjusted life year. And the disability-adjusted life year is essentially a metric that is how long you suffer from a particular disease, whether it's metastatic cancer, anemia, depression, back pain, you name it. How long you suffer, how bad the suffering is, and whether you die, and how young you die. And putting all those metrics together gives you the disability-adjusted life years attributable to any particular disease. So the first thing I'll show you is that the way that we work out how severe something is, so as I said, how severe, would you rather have metastatic cancer or, severe depression or something else, is that there's these things called a disability weight. Now, what you'll see here is that the disability weight for mild anemia is very low. In fact, it is the lowest disability weight in the book. Once you get to moderate or more, and especially severe anemia, yes, the disability weight is getting quite high. But for mild anemia, it's negligible. If you look at malaria is also not so bad if it's mild, and obviously if it's more severe, it's worse. And that's because malaria isn't such a bad disease if you don't die from it. But if you die from it, that's the end of your life, and then the points start then the DALYs come from the loss of life. Conversely, diarrhea, I'm sure many of you have experienced, is a horrible thing to have. And therefore, it does actually ruin your life while you have it, and therefore, it's a very potent disease in terms of causing suffering. So now we can start looking at how do our three diseases that I've talked about, anemia, malaria, and diarrhea, add up. So the first thing is years lived with disability. So this is the concept of how many people in the world right now are suffering with this disease. And you can see anemia is more important than malaria. Anemia is in the light green, and malaria is in the orange, and diarrheal diseases are in the purple. So you can see that anemia is a really important disease for causing suffering in the world as we speak. You know, the ongoing suffering, anemia is a huge problem. What kills people? So this is looking at the number of deaths. And according to the global burden of disease now, an iron deficiency anemia doesn't really kill anybody. But malaria and diarrhea both are responsible for a lot of deaths around the world, although they have been improving over the last few decades. So because they cause deaths, these two diseases contribute to the second metric, which is lives lost, years of lives lost. So there's no years of lives lost caused by anemia, but there's a lot caused by diarrhea and malaria. So when you put these two together, that's when I get the final number, which is the disability-adjusted life year. And here, what you see is that when it comes to disability-adjusted life years incurred by either anemia, malaria, or diarrhea, anemia is not as important a cause, it's the green line along the bottom, as either malaria or diarrhea, which you can see incur a much higher disability-adjusted life year burden. So what this means is that if we provide interventions that cause small increases in malaria and diarrhea, we may be sending the world backwards, not forwards, in terms of improving the overall amount of suffering, the overall amount of burden of disease in the world. What's also really clear is that the disability weight and burden of anemia is really low for mild anemia. And so I'm not sure that resolving mild anemia for its own sake is impactful. And I'm also concerned about using these interventions in areas where anemia is relatively rare, where it's only 20-25%, because there, the majority of people aren't even going to be having an opportunity to get better. Then there's the opportunity cost. So these drugs are not free. They're free-ish when you just make them sound cheap. It's only 0.003 cents a dose, or 0.03 cents dollars a dose, but we're giving them to everybody forever, or months at a time forever. And then it stacks up. So then you have $4 to $5, for example, for a course of micronutrient powders. And what's important then is adherence as well. So if you're giving everybody $5 worth of MMPs, but of those, 80% of them are sitting on the shelf and not being consumed, then you're actually spending $20 per child on providing MMPs. And indeed, the costs for distribution may be even more expensive than we imagined. So there was an analysis done by Spring who looked and found that they estimated that the cost of delivery was not just $5 or $6, not just the cost of the drug, but towards $60 or $70 depending on the model of intervention. But there are a lot of problems with the evidence. So I don't think this is the end of the story, because the quality of our evidence, the quality of the data I showed you before, in my opinion, is not sufficient to actually finalize our decision about what we should be doing. There's a lot of different trials. They've been done in different places using different approaches, and many of them didn't even use placebos. Importantly, we haven't used effective outcome measures that are meaningful to children. Many of the trials didn't use placebos, and some of them just relied on biomarkers, particularly around anemia and iron status. So what I felt was missing was really high-quality evidence of benefit on functional outcomes in children, particularly around iron or micronutrient powders, particularly around cognitive or psychomotor development. And also, given that one intervention is about 10 times cheaper than the other, is there any evidence of a comparative evidence between the two interventions of iron drops and micronutrient powders on anemia, and most importantly, on functional health outcomes? So in medicine, we would call this a phase 3 pivotal randomized controlled trial. But in my view, this hadn't yet been performed for a lot of these iron-related interventions in young kids. And so that said, I don't think you could just get there with one study, and indeed you need to really split the world at least into two and think of places where there's not much malaria and places where there's a lot of malaria. And so we were lucky enough to be funded to do such a trial, and I wish I could tell you the results, but you'll have to wait 12 months. So this is the first trial that we've got up, which is a trial looking at the benefits and risks of iron in children. And this is using something that looks like push-to-Kona. It's actually, if you read it carefully, it says brisk on the packets, not push-to-Kona. And it's basically the micronutrient powders or the iron drops. Everyone gets both, and they'll either be getting 2 placebos or 1 of each. And we've randomized 1,100 babies aged 8 months to the trial, and per arm, so 3,300 in total. And all the babies get a full Bailey's scale assessment at baseline, after the intervention, and then 9 months after the intervention to see if there's any sustained effect, along with measurements of growth, hemoglobin and iron status, and careful monitoring for morbidity. So this trial is looking at all these outcomes that we feel will be important to help us make an estimate of the functional effects of these impacts of these interventions, both in the short and maybe the medium term as well. And so luckily, we've managed to recruit the trial, so we have everyone on trial now, and we will have hopefully some data to share towards the end of next year. In malaria endemic areas, where, as I said, the transient reticulocytosis may enhance the susceptibility to plasmodium infection, there, the question is not just, we don't, does iron exacerbate malaria? We don't want to know that again. We want to know if we can make iron safe. And there, what we're looking is, can we actually make antimalarial cover make iron, can we use antimalarial cover to make iron safe? But then, antimalarial cover might actually just fix everything, because it's probably worse to have malaria in your brain than to be iron deficient. So we needed to actually consider that separately. And so one solution for malaria prevention is a drug called dihydroartemisinin piperquine, or DP, and 3 days of administration can provide 1 month of protection. And we hypothesized that we might be able to see a lot of benefits just from preventing malaria, and that maybe giving iron would provide an additional benefit over giving the antimalarials alone. And so this trial will hopefully start in a few months. It's set in rural Malawi in the Rift Valley, where there's a lot of malaria. And here we've got 4 arms. We've got a placebo arm, and then we've got a DP arm, and then everyone else, and then 2 arms that basically recapitulate the BRIS trial. So MNPs or iron drops also receiving DP. So, and again, we have careful child developmental growth, hematologic and morbidity data being collected. So just to finish off then, I think that the evidence of benefits from iron remains unclear. There's evidence of harm from iron, but again, it's not completely clear. The clinical trials remain conflicting, and there's a lot of underpowered and high risk of bias trials out there. I think we still need high quality evidence, but even if we do get the evidence, this decision is going to be complex. It's going to require, for example, mathematical modelling using the high-quality evidence to estimate net effects on outcomes such as disability-adjusted life years. But beyond that, what I think is really important is that it also requires engagement with communities and with policymakers in countries to understand the values and the willingness to accept risk in these populations. So just to finish off, I'd like to thank my lab back in Melbourne and also my collaborators in Bangladesh and in Malawi and our collaborators elsewhere in the university. Thank you.
Thank you. There's several hands up here already. So I think is it okay, Santa, if we take two
Yes.
to 3 questions at a
It's a
time?
good test of my short-term memory.
Okay, so let's start back here, and then we'll go over here, and then we'll come to this side of the room.
Actually, so I have few queries regarding the treatment part. Like, so I work in Nepal. Like, we get lot of anemic child with malnutrition. So do you need to find out the cause of anemia in all children with undernutrition and go for the treatment, or like you can treat because there is a problem of cost factor and economical problem is there? That is my question. Next question is like, so now it's like you have advantages and you have disadvantages of using iron. So can you suggest just this is the cutoff line whether to treat anemia, especially iron deficiency anemia, when to treat and when not to treat? Especially when a child is not malnourished in iron deficiency anemia. So another is like, so what about, is there any range of serum ferritin or like that, which one is dangerous to the child's brain for especially cognitive functions? Thank you.
Do you want me to?
There was one other question over here. Where was that? I've lost you now. There you are. Sorry. Yes, go ahead.
I thought that was a wow presentation. Thank you, Ryan. I always thought iron was a pro-oxidant, and I always felt it had a lot of the other side of the iron was never discussed. And as undergraduates, we were always taught that if you pick up an Yersinia infection, rule out an iron overload, because Yersinia could never pick up iron. And being in a country like India, where Salmonella is so rampant, whose virulence goes up with iron, and the way we prescribe iron to each and everyone thinking of cognitive effects, your presentation was an absolute eye-opener. Now what I want to know from you is, there is also a mention of zinc and rota. Zinc is needed by rota. All trace elements are needed by the microbiome. So would you really recommend iron to during infancy or no?
So,
or do you have any?
Yeah.
Yeah, because you have confused me with your presentation.
Yes.
You spoke on both sides. You said yes
I wasn't
and no.
good. I was trying to stay on the fence, but I'll answer a couple of. I'll try to remember the question. So the first is treatment. So, okay, the first caveat would be that it's not. So I'm definitely not a developing country pediatrician, and I would defer to the experts in the room and elsewhere. But certainly there are obviously, firstly, concerns with treating someone with severe acute malnutrition, especially if they're sick, febrile with iron, or have evidence of sepsis. You should be careful about doing that. In terms of giving iron, so it's a completely legitimate approach, particularly in young kids, to give them some iron. If you diagnose anemia, to give them some iron and see if they respond. And because you're monitoring the child, you can see, and if their hemoglobin comes up, you've made the diagnosis, and that's fine. And if it doesn't come up, then obviously an alternative diagnosis should be sought. I think there were two sort of related questions then around what do I actually think and what should be done. So I think that I'm glad this is being recorded, and but my view is that you need to be seeing a high prevalence of moderate and severe anemia in a population before you should be introducing iron interventions. So if you've got a population where, say, 25% of the kids are anemic, of whom most of them have mild anemia, and then there's a few moderates, just say it's 25% overall, and then 20% is moderate, 20% is mild, and 5% is moderate, hardly any severe. I'm not sure about that sort of population. If you've got a place where there's a lot of anemia, and a lot of it is at least moderate in severity, then I'm prepared to entertain that in these populations, these would be the places where if you could improve that burden, you would start seeing that benefit. But of course, those are also populations commonly where there's a lot of these infections as well. So it does make it more complicated. If you can control, particularly around malaria, so ensure children have access to malaria diagnostics and to treatment, and if you can if you have some certainty around management of diarrhea, then maybe it's something to consider. But I do think something that I've not talked about in my presentation is that there are plenty of other people you can give iron to. So there's the mother, there's the pregnant mother, and in many of the countries that we work in or that we see, not all the women are not during pregnancy getting their full dose of iron supplementation, and we know very clearly that ensuring that women get high full courses of their iron supplementation in pregnancy does appear to be safe. Those trials have been done, and improves birth weight. And birth weight improves iron endowment to the baby, and that maybe gives you a heads up for the baby to have an advantage going into the future. So I think, because I do think, yeah, so I'll stop there for now.
One, you talked about Pakistan and the diarrhea and the dysentery thing. Background rates breastfeeding in Pakistan within 30 minutes is around 17%. And it's like exclusive breastfeeding for 6 months is around 37%. This is a WHO publication of 2017. Given that one single top feed is enough to change the gut microbe, can you say that this is because the iron was given that this child developed and increases, number one. Number two, we know that zinc deficiency increases the risk of respiratory tract infections. As the Sridhar said, zinc and iron compete. You give iron, you depleted child is already depleted with zinc. That could be the cause of the recurrent respiratory tract infection rather than the iron causing the recurrent respiratory tract infection. Third, hierarchically, if there's an iron deficiency, the iron is going to go to the production of hemoglobin at the cost of other tissues. There is enough evidence which says that if there is iron deficiency, metabolically the most active part of the brain in a 6 to 23-month-old child is the hippocampal gyrus, which has got iron enzyme systems which are iron dependent. And it has been proved that there are decreases in the size of the synapses, number of synapses, amount of neurotransmitter that's been released, and the plasticity. This occurs when there's iron deficiency. So given all this, can we look at just say mild anemia, I won't give iron, because if there's mild anemia, he's already iron deficient. We're looking at iron status, not at iron as a cause of anemia. And it has been proved that even if their patient is not anemic and is iron deficient, it is going to affect the function of the temporal lobe.
So to pick up on your point that there is a disconnection between anemia and iron status, I think that is an absolutely true point, but possibly not so much in India. So in India we see a lot of the anemia is related to iron deficiency, and there's more. It's probably a better hemoglobin is probably a better diagnostic. It's not a great, but it's a better diagnostic test. And I'm saying that in comparison to, say, sub-Saharan Africa. So in sub-Saharan Africa, the relationship between hemoglobin and anemia and iron status is dismal. And it's actually very hard to make any guesstimate about the iron status of a child based on their hemoglobin concentration. That said, at the moment, it's very hard to do population estimates of iron status for a couple of reasons. Firstly, because you need serum or plasma, which requires more pre-analytic collection complexity and processing. And secondly, because iron status itself is highly difficult to measure in populations where there's a lot of inflammation, and so it's hard to be sure. I'm not sure if I covered all the points that you raised there, but.
Yeah, if I can give a little bit of Indian perspective, like I belong to a hospital which is a trust run, and we cater to the lower middle class and poor class. And routinely, because we see so much of iron deficiency, routinely we do, if the hemoglobin is around 10, routinely we are doing a iron status, and because in eastern sector thalassemia is so prominent, so we do our HPLC. And we see most of our children is suffering from iron deficiency. It can be mild, it can be moderate. So what we do during the infectious state, we don't give any iron, but during discharge, we supplement with iron. So in a country like India, where you have lot of developmental issues, so the supplementation is always a problem. So at least in India, and I'm sure in Nepal, Bangladesh, we do supplement iron. If we have a documented deficiency, hemoglobin low, and at times we get an opportunity to do the iron status also. If there's documented deficiency with iron status documenting, then definitely iron treatment we do. We do at a therapeutic level of 6 milligram per kg, but if we don't have the option of getting iron status, but we see the hemoglobin on the borderline, we may even give a little lower dose, that is 3 milligram per kg. But I think in a country like India, where we have lot of issues, we have fussy children, we have poor children, so one end it is poverty, the other end it is in spite of having adequate finances, they don't take, and with a change in transition, even people are going towards fussy food eating and fast food eating, so obesity. And we see even in small neonates or small infants who outgrow, they also have a deficiency in iron, particularly those who are infant formula fed or whatever. So I think in India, we have to give iron B, whatever may be the cause. I would surely ask the experts of Indian expert, Dr. Mohanty, please. What is your practice in Bombay? You also belong to a big hospital.
Thank you. I would rather bring another aspect to this. Our mothers are usually iron deficient in pregnancy, particularly the last trimester who are anemic and their iron reserve in the baby is less. And although WHO says you delay the clamping of umbilical cord, mostly the busy obstetricians nowadays in nursing home practice, they don't do. They have no time. So what we have seen, we have read a study about 2,000 babies in one arm, the other arm 2,000 babies. We have milked the umbilical cord. They have said, if you save time, at least milk it 3 times. And we have followed up these babies for 1 year. We have seen not only the physiological anemia was not there, not only that, they also, the growth and development was more, and by DDST we followed them for 1 year. The developmental also they are faster than the control group.
Yes.
So this also should be insisted upon, not only iron supplementation, other modes of what which are near hand, we should also insist upon it.
See, we don't have a large scale study, at least in India, to support that whether what happens in micronutrient deficiency, what I was trying to find out. I'm sure when you look at a large scale study with the endpoint, it may not be the growth, but it will be the incidences of recurrent infection coming down. Overall cognitive function, we did a I won't say it's a large scale study, but it was a moderately sized study where we gave a population, it was infant study, where we gave a population with a fortified iron and not a fortified iron. And we did a very meticulous, it was a Nestle study only. And we did a very meticulous cognitive function assessment. It was done really meticulously across India. And we did find there was a change. And there are a lot of evidences which shows. So a country like India where we don't have all the resources to do a very definite, I think whatever you're trying to say that iron supplementation will be really of a good, there may be some benefit somewhere, but there may be mostly a benefit in that cases, a population of this type of developing world where there is a mass scale deficiency.
So
Dr. Manjari,
she wants to say something.
We have a whole lineup of people.
India has always surprised me. We have a large iron ores next only to aluminum, and we continue to suffer from iron deficiency. We have a lot of sun, and we suffer from vitamin D3 deficiency. So what makes me think is that, do we reconsider the level that we have? Whether climate has anything to play? And if you see the physiology of iron, it is treated as a bad boy, always chaperoned by some protein, because it is risky when it is inside your body. Your observation or your paper is very important, because what do we treat? Are we treating lethargy? Are we treating intellect? Are we treating growth? Why do we treat diarrhea directly? Why do not we treat malaria directly? Why do we have to withhold iron to treat these two conditions?
So there's been a couple of things to respond to. So the first thing to say is that the major point I'm making is not around treatment of anemia. I would never argue against treating anemia, particularly in a child who's been diagnosed with anemia, and if possible with iron deficiency. And as I said, it's normal to, for example, not do an iron study, especially because it's expensive. Even in Australia, we wouldn't necessarily always do an iron study because it takes more blood from the kid, and that's the last thing you should do in an anemic child. And instead, you can just give them some iron and come back and test them in a month or 2 months, and if they've improved, great, fantastic. So the treatment of a case, I wouldn't argue with that as an indication for iron. What I'm talking about is operating out of, say, Angawari health centres or sub-centres in the villages of field staff who are not necessarily highly clinically trained, trying to detect tiny effect sizes, but maybe significant effect sizes, where what we're trying to do is achieve a net benefit on health. And so that's a complex argument, and it's very different to treating an individual patient in front of you, where of course you need to do the right thing. The patient is here; they wouldn't be here if there wasn't something wrong. And you've diagnosed anemia, and you can treat that. And of course, you can spend even a few seconds and instruct the mother about the potential side effects, and maybe you can even follow up the child and make sure all is well. That's really different to the community setting. In terms of the points around, obviously, obviously you should treat infections by treating infections. So obviously you treat malaria ideally with antimalarial or with antimalarials, and you treat diarrhea with oral rehydration, maybe with zinc in some cases, and you obviously try to prevent it by improving the hygienic status of the setting. I wouldn't argue that you would try to treat those conditions by inducing iron deficiency. Yeah.
There was a question here and here. If we could take those two and then respond.
Thanks for a brilliant talk. You might have just addressed it in your last answer there, but I'm very interested to see that you're addressing the malaria story with the iron supplementation. But can you comment on, or do you have any plans to address some of these other infections or address the diarrhea simultaneously with iron supplementation?
The other question was over here.
There is a government program, fortification common salt with iron. What you say, it will be do good or harm?
Sorry, can you speak right into the mic?
There is a government program to fortify common salt with iron. What will do? It will do better or any do harm? Opinion.
So I'll come back to, so I think that so one thing that we're going to look at is we are collecting individual household level water sanitation hygiene data, which may be a little bit blunt, but we're collecting it from that trial that I mentioned, or both trials that were mentioned, and among the analyses we'll do, probably not initially, but subsequently, will be to see whether if there is an effect of iron on diarrhea, which we don't know because we haven't got the results, but if there is one, then we'll be able to, one hypothesis we'd have is that given that the effect of iron on pathogenic species seems to require the presence already of pathogenic species at baseline, whether there's any association with the individual wash situation of the household. But just to say, like actually a point that Usha made earlier today, that the issue here is that you wind up having everything falling down at the poorest households. So the families that have the worst water sanitation hygiene or maybe have the highest risk of infection will probably still be the same ones who do, I agree, have the most anemia and also and maybe the lowest iron stores ultimately as well. So we have this diabolical problem that it's often the families who are going to, or the children who are going to be most at risk of some of the interventions that we give, who are also most in need of it. I think we need to acknowledge that because that's actually the crux of the problem we're now at this point. Your comment about double fortified salt. So here you're giving perhaps iron, so I assume people don't just eat the salt, they mix it into the food and they have, it's diluted in the food and you're increasing the overall iron content of the food. Certainly there were some of the fortification studies which were essentially using fortified biscuits in the Ivory Coast and home fortification with even low doses of iron in Kenya, that the Zimmerman group still showed increases in pathogenic gut microbiota. But I couldn't comment specifically on DFS at this stage, other than to say that it's clearly an important clinical outcome that would need to be monitored.
Yes.
Regarding the diagnosis of iron deficiency anemia, what is the role of RDW? Because it is one of the earliest changes and it is very cost effective because everywhere you cannot get the iron status estimation, that part. And if you do that, you can pick up the iron deficiency nicely.
Absolutely.
And number two is that we often miss CKD in children because we don't think about it. Growth failure and anemia is present in CKD, and these two are present in malnourished children where there is stunting as well as anemia. So we have to consider that part. And sir, you have nicely described the iron poisoning, that is toxicity, but it is dose related. About 60 milligram per kg of elemental iron is given, And is there any role of state X-ray abdomen very immediately after taking because you can count the number of pills that can give an estimation whether he has crossed the toxic level also. Or also the multi-dose activated charcoal if the patient is coming within first hour. So it is also called the guard dialysis by which you can eliminate the iron. Though iron toxicity has got long-term bearing like renal failure, liver failure as well as the stricture. You have nicely described the GI hemorrhage, but the strictures are also present inside those things.
I'm trying to remember all the points. So the RDW. If you have access to an automated analyzer, so a Coulter counter that can size and count the red cells as well as measure the hemoglobin, then absolutely the red cell indices, so MCH and MCV, of course, and RDW are important. Red cell distribution width basically means that when you look at the blood film of someone with iron deficiency anemia, they have some small red cells and some bigger red cells, so they have a big distribution of the red cell number, the distribution of red cell size. So that's important, but it doesn't work. It's not possible if you're not measuring on an automated analyzer. So for example, this was a while ago, but when I was in the PHCs in Karnataka, I saw that they used the cyan methemoglobin method and calorimetry, which is basically therefore just making a solution of blood in this reagent and then measuring the absorbance. So you're not going to get an RDW there. You'll just get an HB. I agree about the point about chronic kidney disease, and I agree about all your points about iron overload. My point is that, we don't know what's happening out far from the hospitals. And things, and my concern is when you're giving these interventions and you're far from the hospitals, then you have the access to doctors like yourself is not so strong.
Okay. Two final comments here, and then Usha.
Good afternoon. So my question is that being in Indians, there where this anemia is very prevalent in under 5 groups, it is more than around 60%. So in this context, when anemia leads to malnutrition, leads to under 5 death. So in this context, can we take anemia as a dangerous thing for causing diseases? Number one. And number two, there is a recommendation by all these neonatology books that we should start giving supplementation of iron after 2 months of age, and particularly for these IUGR babies and those who are low birth weight babies. It is a routine regular recommendation by the books. So in this context, how what you have presented is actually confusing to us, that iron is not at all very good, or whatever we are giving is not good for in terms of causing other diseases. So how please clarify about this, whether to be supplemented after 2 months for this infants of IUGR, and particularly in context of India, where the anemia is very prevalent, under 5 mortality is very high. So should it be taken as a not good, or it is a positively taken?
Shall I comment there? So just on the point about the association between anemia and mortality. So there is a clear association on systematic reviews between anemia and child mortality. There is an association between anemia and mortality of everybody. So the elderly, heart failure, renal failure, cancer, any other failure you can name, there will be an association between anemia, because anemia is obviously in those conditions a symptom of impending horror and terrible outcomes. But the anemia, but the anemia that really kills people is, of course, severe anemia. And the anemia that really, really kills people is particularly seen in malaria endemic areas, where it's severe malarial anemia, where you have a hemoglobin of 3 or 4 grams per deciliter or even lower, and there you need transfusion to save the life of the child. In India, my experience, but I have nowhere near as much experience as everyone in the room, is that type of anemia is not commonly seen, and you do see the rare child with a hemoglobin of 3 or 4, but it's not the same as severe malarial anemia. So I agree that my second point is that there was a second trial. And my second point is that had severe anemia been amenable to iron in such a way that then improved mortality, the results of that trial I showed you, the PEMBA trial, and all those other trials, we would have started seeing a signal or an effect on a beneficial effect on mortality. Actually, there's not been any beneficial effect on mortality in these trials. There was a second trial that I didn't present, published on the same day in The Lancet in Nepal, which is near India. And that trial was aiming to show a benefit on mortality too, but had to be stopped early by the DSMB because it was futile, because they weren't seeing an effect of iron on mortality in that population. So I'm not convinced that iron interventions is going to have a beneficial effect on mortality in babies. Your point about low birth weight is important, and indeed serum iron, and so obviously low birth weight babies are at higher risk of anemia and iron deficiency, and I think that there is an established practice. I myself haven't reviewed the key data around that in terms of my formulations, but I would say that there is low birth weight babies have a long-term increased risk of infection. So it's certainly something that I would only do with care and with monitoring.
Okay, 2 very quick questions here, and then Usha.
Thank you very much for an eye-opening, and I will say that something new to us, that are we doing wrong things for last few years? But my observation that our main target is growth, development, stunting, and the child overall mortality and morbidity. Anemia is so much dangerous. To me, I see a lot of cases of death due to anemia, and which in that case, it was mostly due to iron deficiency anemia of mother and children. So it is quite a serious disease, and malaria is not so much prevalent. Malaria is present in malaria endemic zone. So if we target for mass improvement of our child health and child growth, nutrition, and development, so we have to stick to our old belief that iron is important and iron fortification is important. What will happen? After 2 or 3 years, you said that iron deficiency anemia will be improved automatically. It's true, it will improve. But by that time, child cognitive development and intellectual development and growth has already suffered, and there is no way of repairing it. So I think it's a problem and it should be treated, and even not that, fatigue, poor performance of the mother. I see a lot of mother earlier days that eating clay, make like bread, telling their husbands during pregnancy that bring me some that is called bread made from clay, that is mud, bread made from mud, because they develop pica. Mother are eating pica, mother having habits of pica, children are having habits of pica due to iron deficiency, and there is poor performance in the mother. All mothers are saying that we are fatigued, we cannot do work. Most of the mothers in Bangladesh where there is prevalence of iron deficiency in mother and children. So for me, what I do, in mass scale, iron should be given, what is my belief, but as a pediatrician, if any patient comes, at least I will do a CBC. And by this CBC, we can, by MCV and MCH and RDW, you can have some idea about what to do. So I think, you definitely, you also said that it needs a lot of study and more extensive study in different zones. But for us, for Bangladesh, and I think for India, iron supplementation is crucial.
Okay, Usha?
Thank you very much for a very balanced presentation. And I know it's always a challenge when we're dealing with what's done at individual pediatric practice versus this is, what informs policy and sort of the do no harm. One comment and a question as well. The comment is, as you rightly said, even the adverse consequences, depending on which review you look at and at when you look at, those estimates swing around to a certain extent. And I just wanted to share, and you're familiar, Leila was part of the MNP trial we did in Bihar. It was not placebo-controlled, and there was a lot of concern even it was through the Anganwadi centers. But we had a data safety thing, and we reported that we did not find any differences in morbidity. And we didn't see big differences in certain outcomes, but we clearly saw, despite the blunt instruments we had, that there was improved development indicators. So I just wanted to share that, as this is still work in progress, and yes, that's something which is being done through the healthcare sector. The second question is related to the comment of even at a population level, the high-risk groups being the low birth weight child, the preterm child who has lower iron stores and is at even increased risk for infections, for poor development, and for iron, and they're all intertwined there. So I think that's important as for the practitioner as much as in programs as well. And would like to hear your views. And I just want to end off with a last comment so that I don't want people to leave confused. There is no doubt in my mind that the safest way to get iron to the child is through the mother, by making sure she doesn't get, she has adequate iron stores when she's pregnant, she has a safe pregnancy outcome, and the experience you said of even if they can't shorten the milking the cord, that is the safest because you bypass the gut. You're having direct blood transfusion from the mother and helping the mother to ensure that, I think, is the safest route. And this is, when that's failed, we are struggling with pumping iron into the infant. So I just want to make sure that that message is clear, because we're really dealing with how does the gut handle and that risk. Malaria is a different thing, but I think that's less of a concern in this region. So I'd like to hear your views on, the high-risk groups, even at a population level.
Yeah. So just to acknowledge the gentleman first, I agree. And I think, so I know there's a lot of pica, we've seen a lot of pica, and I think hopefully some of our studies will provide some further insights into the effects of iron on child development. I'm aware of Leila's study and those sort of programs, and I think that obviously the concern is around placebo. I think once we have the data with the placebo, that'll be beneficial. And yes, I couldn't argue about the point of giving iron to pregnant mothers, ensuring they get the iron. If possible, making sure the pregnant, because that also, if you can get if you can eradicate, reduce prematurity, improve birth weight, and then at birth ensure that there's delayed cord clamping or maybe milking of the cord, you obviously give the baby the best shot at getting through that first critical year with their adequate iron stores. So I think, I fully agree. I think the mother is and it is safe to give iron, as far as we know, to pregnant mothers.
Yeah, I'll just make one quick comment on the on iron deficiency and anemia. Those are not synonymous. Anemia can happen, as you said, in any chronic kidney disease or in malaria, where we really don't need to supplement. Once we treat the disease, automatically the hemoglobin goes up. But iron deficiency, which we see in India, we do have documents where even in community level, patients absolutely healthy will have iron deficiency in form of anemia, which we also can supplement by microcytic hypochromic anemia, but otherwise it's normally the normocytic part. So again, coming to a community level, it's very difficult. I don't think it will be very easy that today we'll say community-wise we have to give iron to all, barring those IGR and all those areas, because if some hospitals, they are milking, but all hospitals are not milking. So maybe we have to routinely supplement IGR babies and all. But in the community level, particularly if you have any evidence that the child is having anemia with iron deficiency, those child will be a treatment which you agree. But by and large in community level where we can routinely supplement, again remains a question. Unless and until we have some amount of evidence, I don't think even in India we have a routine supplementation. I think Dr. Sridhar Ganapathy has been asking for a long, just one.
Yeah, I'm sorry. I just wanted to complete what Usha said, and I thought that we need to know the other side of iron, that it does increase virulence of the enteropathogens. There is a possibility of translocation of enteropathogens. there is a possibility of predisposition to many diseases. So you treat when it is needed and think before you treat certain things where it is not needed.
All right. Thank you so much. I was asked to provide a few comments in summary. So I'm going to try to do that. It was a long day and an immense amount of information. But I'm going to try to provide a very brief overview of what we've been hearing today. So we started the day looking at the prevalence, the magnitude of the problem that we're trying to talk about. And what we saw is that there are multiple forms of malnutrition in young children, in infants and young children. Stunting, wasting, micronutrient malnutrition, which we are all aware of, affect millions of people globally. But we have a growing problem of overweight and obesity. And at this time, we are still not adequately considering the extent to which those problems may be affecting the same children or different children within a household, within a country. Unfortunately, our national level statistics are masking substantial variability within countries, within regions, and this is critically important so that we can design programs that actually address the people who are suffering from those deficiencies as opposed to a population where we may or may not. We have to understand beyond a national level what the actual magnitude and distribution of the problem is. Unfortunately, much of our data on micronutrient deficiency is old, and we are addressed with what we've been talking about here quite substantially in this last presentation. We also know that for all forms of malnutrition, the etiology of those is multi-faceted, it's complex, and we can't go on the assumption that treating one element of that, such as just iron, when anemia, we know there are many other causes, and we need to be careful and design programs that look at that as a comprehensive issue, looking at the many forms of the many causes of those issues. We went from there to looking at what children eat, and we heard from Dr. Bentley's presentation that there is good consensus and guidance on what is healthy eating for infants and young children, not only on what foods they should consume, but how they should consume them, the frequency with which they consume them, the way in which food is provided to young children so that they develop healthy eating habits, responsive, attuned to their own needs. We heard a nice presentation on that that was given by Dr. Usha from Dr. Bentley. There are global indicators that are tracking progress in our efforts to address those different feeding habits. Breastfeeding is getting better, although we have a long way to go still in reaching the alignment with the recommendations around exclusive and continued breastfeeding. We're lagging on complementary feeding. Poverty is still a very strong predictor of poor complementary feeding across the world. We are lacking information on beverage consumption, and yet where we do have that information, we know that it may be an important contributor to calories and energy in the diets of children without necessarily providing additional nutrients, which may be a risk for our problem of overweight and obesity that's coming out. We heard a very nice summary of the concept of responsive feeding, how mothers should identify and respond to the cues of children, and that this is a critical step in not only what children eat, but how they eat so that they develop, so that they're well nourished, but at the same time develop healthy eating habits moving forward. From there, we heard about several of the different types of interventions that are particularly focused on trying to improve the quality of the foods that people eat. We heard about what some of those interventions are, the importance of behavior change, communication, and increasing not only knowledge, but also skills in how can we support mothers, caregivers to improve the quality of foods that are given to children. And we also heard that it is not only mothers who influence those, it's also the mother within the context. It's the father and the mother-in-law and mum who are very influential, the community that are very influential in deciding what, when, how children eat. and that effective strategies to address those really need to consider the community, the family, the context in which children are eating, and even beyond that family and that context to the food environment and what foods are available, what is being promoted, what children have access to. A few of the gaps that were highlighted in this area, there are several programs that we know, unfortunately we know very little about effective approaches to address, prevent and control childhood obesity. And we know little about the cost of many of the interventions that, including the interventions for promoting improvements in dietary intake. From there, we move to a discussion about food composition tables. It's important for us to know, if we're going to understand what children eat, we need to know what the nutrients are in the foods. And I think all of us, it was an eye-opening presentation for many of us who have even been working in this field for a long time, to hear about the importance of understanding the variability, the sources of variability of nutrients in foods, even the same foods, which has to do with the actual variety of the food that is being planted, the crop that's being planted, to do with the way the recipes are being prepared, the cooking styles and so forth, but also on the quality of the data itself and how those data are being compiled and turned into a nutrient composition table. There are clear criteria for what an ideal food composition table looks like, but those are rarely actually put into effect. And many of the composition tables that we have are the best possible, but they're not reaching that ideal because of the cost and the complexities of that. There are inconsistencies in the way that nutrient composition tables are being presented. Some foods are missing, such as the fortificants, the fortified foods and the nutrients that are coming from fortified foods, and we saw a nice example of that from what happens with that in Brazil. We heard about the need for national, or at the very least regional, food composition tables, because we know that there are some of those factors that are affecting that variability obviously are going to vary nation by nation, and I would add to that probably even within a nation. India, the cooking styles and diets are very different in the north and the south, and agricultural crops are probably also very different between the less arid and non-regions and so forth. But the good news of this is that InFoods and others are bringing the science to this area and improving it and helping us understand how to get that information in a robust manner. And then to conclude, we had a very interesting, thought-provoking discussion on iron and anemia and the risks and benefits of treating and not treating at a population level. And I think I just really want to perhaps focus on the emphasis that it is never in question that when a child is diagnosed with anemia, they require treatment. And there's very nice procedures and algorithms for making decisions at a clinical level related to the course of treatment, the follow-up that's required, and the appropriate approach to ensure that that child recovers and follow through their progress. At a population level, we know that there are many population-based programs, and what we're trying to look at, or what Dr. Pasricha was trying to emphasize to us, is that at a population level, fortification, supplementation through population-based programs, that's where we need to be doing and thinking at a population basis the risks and the benefits, and remembering that that iron has a clear positive need for the human body, but there's also risks involved in those who don't need it. And if you have a population-based program, there will be some people who are not deficient who consume those supplements or consume that fortified food. And so this is where that need for risk-benefit analysis comes in, and that our knowledge is still growing in terms of how we can do that, possibly looking at disability-adjusted life years. But we also need more information so that we can understand better the functional outcomes of correcting anemia on a population basis, and the potential risks related to diarrhea and potentially other infectious diseases. So I think I'll stop there and pass it back to Natalia.